41 is a Krishna. So I think this is the time for us to start. And uh, basically, this is arranged by the Pujya Muktanand Bapu Medical College and Research Institute at Chapada, Human Health Circle, together has initiated this process. Myself, Dr. Rajesh Mehta, I am a dean of that medical college, Muktanand Medical College. And I also introduce Hema Mehta, who is a proprietor of the Human Health Circle. So basically, together, uh, we want to start the virtual medical college. But if you use the word college, there will be a problem. So we are using the word education. So basically, when I say education, remember this is a college, a virtual medical education, because lots of colleges are now starting all over India, and hardly there is a quality medical education in a sense that the way we used to learn in a in-depth learning process. Now, of course, the videos and the animation, virtual reality, so many aids are there. But I don't think that is up to the mark medical education. Over a period of my journey of, let's say, 40, 46 years of journey says that gradually there's deterioration in medical education. And with help of virtual medical education, we want to complement the existing structure. And more than 800 faculties across the India has joined this movement for this virtual medical education. The purpose of today's session, Dr. Sridhar and Dr. Avni, both are experts as far as data analysis and data interpretation is concerned. So I thought let us start with this topic as the first session, and then gradually we are going to start not only the 20 departments of medical college, but the specialty and super specialty will also be covered on this platform, so that the best teachers of the world can be brought for this purpose, and the students have a freedom to learn from across the world. So that is the purpose of this session. Once the data session is over, let's say after 1 hour or so, there will be discussion on future planning on this topic itself, how we can take it forward. So some of you are from public health background, some of you are MBBS, some of the specialists, some of you are administration. So I think Dr. Sridhar, who is having the vast experience working not only in India, but some of the outside country also, is a pediatrician, and we were studying together. So uh, I hand
Bluetooth
over
mode,
to Dr. Sridhar.
FM mode, hot
Yeah,
mode.
yeah.
Hello, can you hear me?
Yes, a little bit louder. That would be better.
Okay. Uh, am I audible clearly?
Yeah.
Yes, clearly
Okay.
heard.
Okay. Yeah. So I hope my internet connectivity stays stable from wherever I am. I have a couple of alternatives also. For now, it seems to be doing well, but in case it becomes weaker, I will switch off my video. So thank you, Rajesh, for inviting me here, and thank you everybody for registering and coming on to this new venture. We are hoping that this what we are kicking off today will grow into something meaningful and useful to a wider audience. So Rajesh was very kind in saying I'm an expert in data analysis and interpretation, and my only submission there is that I have learned whatever I've learned, not really by studying, uh, uh, doing courses in data, uh, handling and crunching and all of that, But basically, as a part of the effort to try and get large scale programs, particularly, in fact, small scale and large scale. Until 2000 or so, I was working with small NGOs. And then for the last 20, 25 years, I've been mostly working with different state governments, trying to see how, at a large scale, the health outcomes that the states want to achieve, how they can be optimized, how they can be maximized. So in the process, I have picked up whatever I have learned, and it's been a very interesting journey. I have enjoyed it. And I hope that today I'll be able to share a few stories from that journey with you. And I'll be telling you mainly stories. It's not, and there are not too many people, so I think we can even say that you can stop me and ask me any questions that you want at any time. If you want me to give you any more details of the story that I tell you, but I'll try and finish in about 20 minutes. I don't promise, and I hope you don't take it badly if I go over by a few minutes. Let me share my screen.
बोल શું કામ બોલ
સીધે બને તો થોડુંક મોટેથી બોલવા પ્રયત્ન કરજે, એટલે મારે હવે સાંભળવાની થોડી તકલીફ છે ને.
No. If I'm not loud enough, please tell me, and I'll be happy to speak louder. It's just that I don't want to make it too loud for everybody. Okay. Wait just 1 second. I'll share my screen and let me know if you can see it. Can you see the screen?
Yes, we can see it.
Okay. So most of the fonts are in this size, so I think that should be fine. I had initially planned actually to have a lot of data to show you, because we have gathered a lot of data over a period of time. But then I thought, since this is the beginning of a longer series, let me focus on just a few stories. Okay, so let me begin. And, let me begin with one case study, an experience that I had long ago. This was nearly 20 years ago. We had been working for health and nutrition across some 8 large states in India. And from one of the states, and I don't want to name the state because it's not fair to, it might not be fair to people who are there. So I suddenly got a phone call in the middle of the day from the Secretary of Health. There was a bit of a panic, and they said, "There's a major problem, and we want your help." I said, "What is the problem?" I said, "Oh, you know what? There has been a major reduction in severe undernutrition in our state." It was, I don't remember the exact figures, but approximately it came down from 15% severe underweight to about 6% severe underweight. This is in children. Now, NFHS, the National Family Health Survey, that it one of the many bits of data that it collects is the anthropometric data, the height and weight of children, the age of children. From that, they derive different indicators for malnutrition. So one of the indicators, which is severe underweight, which is what ICDS also reports on, that had registered a really major reduction. And the state said, "Oh, you know what? We have to claim credit for this." What was the problem? The problem was that for at least for the last 15, 20 years before that, they had been reporting as a routine part. As you know, ICDS reports this every month. Around 2% was this severe underweight rate that they had been reporting for so long. And the secretary was in a dilemma. So how do we now? I want to claim, which is due, correct? I mean, they had actually achieved a reduction from 15% to 6%. But how do they claim that reduction without admitting that all the reports that they had given all these years was all fudged? It was wrong data, right? And I had to kind of say, look, I can help you with data in many ways, but one thing I cannot do.
తగ్గలేదండి అసలు
దేంటి ఏం తగ్గలేదు జ్వరమా
ఈవినింగ్ మాకు మళ్ళీ వస్తుంది అసలు వామిటింగ్ సెన్సేషన్ వచ్చి అసలు ఏం తినలేకపోతున్నా అసలు
Okay, can you hear me? Sorry, somebody was talking, so we had to unmute everybody. So the point was
now nobody will be unmute themselves. Sir, if you want to allow anyone to unmute, you can allow specific person to unmute. Okay, nobody can unmute themselves.
All right, thank you. So anyway, the long and short of the story is that there was a major achievement that the state had made, but because they had been reporting very exaggerated reports, exaggerated data about the low levels of malnutrition, which is all wrong, there was no way they could take credit. And I told them, look, I just cannot help you with this, because you either need to say that NFHS is wrong, that 6%, it was not 6% as they're reporting, actually it is 2%. Or you have to say what we had been reporting is wrong and what NFHS is saying is right. And NFHS, by the way, as you know, they're large-scale sample surveys, they're pretty accurate. So these kinds of complexities are what define in practice the use of data. And so it's the complexities arise from different users of the data. They don't arise from the data itself. There are things that can go wrong with the data, but more importantly, the question is who really needs data? Are people who are in decision-making positions, are they really using data to make decisions? And more importantly, who decides what data to generate? In this case, for example, who took the decision to report grossly underreport severe undernutrition in the state? Why did they do it? Right? There must have been some due process over a period of time. People must have decided no, and probably government of India was putting pressure, saying you have got too much of malnutrition, so you should reduce. So they said, okay, next month we will reduce. This is how data finally gets used, and therefore we have to understand that it is in this complexity that we end up talking about data, and of course data is much more than that. So let me take you through a few concepts related to data, and then a few examples of how it's actually been used in healthcare or historically, right, over a period of time, how it has been used usefully or not usefully, correctly, wrongly, whatever. So finally, who generates data and who uses data? So I've just listed some important stakeholders who are the main generators and users of data. There are researchers, then there are actual service providers, the doctors, nurses, health workers on the ground, the managers of health programs, whether private or public. Then there's the industry, the pharmaceutical industry, the diagnostics industry, for example, the ambulance industry, and so on and so forth. And of course, all the equipment manufacturers and so on. So there is the whole, they also use data. They very badly need data, right? Without data, they cannot operate. Finally, policy makers, of course, but then you should not forget that, in fact, most lay people also use data. So data in healthcare is about a very, very vast range of users. And one needs to be cognizant of the entire range to say what, where is it that, those of us like us who are now interested in understanding data in healthcare and how to use it, we should be at least cognizant of the wide range of users and how they actually do it. One question that arises that has come up over a period of time, and it has been asked many times, but at least something that we have realized in real time, is that one of the major problems with the way that data is understood and used is that those who are actually managing health programs or providing health services are generally not considered the generators of data or even the users of data. They are just expected to carry out their services, provide services. That's it. And then there are this very exclusive community of researchers who think of themselves as very special people who will produce all the knowledge so that these workers can do their work. And it is this dichotomy that has been perpetuated, including by, for example, the way that publication works, including how research is generated, is driven primarily by publication rather than by benefits to society and so on and so forth. So because of all of that, this division has perpetuated, and we are in a situation where where these two actually, if they combined together completely, that is where the users and generators, basically the service providers and the health managers, became also researchers, where they started seriously understanding how to use data to understand problems and solve them. That is the desirable goal that we should be having. And that's something that's becoming more and more clear. We don't know how to do it. In practice, finally, because if I'm let's say a health manager, I'm responsible for making sure that in one district, the health outcomes improve over a period of time. I need to apply the methods of science to it, but I don't, because I'm only applying guidelines that come down from above and saying these 5 tasks have to be done. Somebody is going to do it. And whatever data they generate regarding that, I have to send upstairs. Instead, imagine a situation where I, as the person responsible for data in this district, actually am using my public health skills, my data skills, to define each problem in granular detail, understand why certain problems are persisting and not getting solved, and hypothesizing solutions, testing those solutions, and finding ways of actually improving health of the people under my charge over a period of time. This is how it should happen. Somehow, for some reason, that is not happening. So let us move to a few examples of how data has actually informed how different health problems have been solved or not solved. And I'll take a few simple examples which everybody should be aware of, because I'm not really 100% sure of what are the backgrounds of the people on the call today. So, if you go back to the 1970s, 60s, 70s, 80s, most of us were thinking about maternal health as primarily as antenatal care. So antenatal checkups should happen, and then people can deliver. We will train dyes, and they can go and deliver the babies, because at that time anyway, about 80-90% of people were delivering at home. So antenatal care was the main thing, and dye training was the other main thing. In around the late 80s, early 90s, a major piece of work was taken up by Columbia University. In fact, the 2 women who took up this research were themselves not doctors. One of them was a nurse, the other was a public health, had a public health background without being a medical doctor. And they looked at data from across the whole world. Different countries at different times looked at historical data, looked at all kinds of research. put everything together and said, hey, you know what? The problem with maternal mortality is that it is not going to be solved by either your TBA training, TBA is trained birth attendants, DIEs, or it's not going to be solved by antenatal care. The other thing that was very common at that time was a high risk approach. That is, if the woman is less than a certain height, or has anemia, or has a bad obstetric history, or a whole range of things, which is again prevalent today. But at that time, it was very clear that we used to have something like some 30, 40 possible criteria for high risk. And by the time you applied that, almost everybody in the population, every pregnant woman would be high risk. At least half of them would be high risk. And what they pointed out from looking at all this research, they pointed out a few things. One, that maternal mortality is caused by a very few direct medical causes, 4 or 5 of them. All of them are neither easy to prevent nor easy to predict, that they manifest as complications which have to be treated medically at the earliest possible, and only then can you start saving lives. And that if you look historically at Western countries, they have been able to reduce the maternal mortality. In fact, most maternal mortality rates in the West, in practically all Western countries, had come down to very low levels even by 1950s. What was the technology that they used there? And basically they achieved that by using the technologies that were available, medical technologies. What were the technologies? Anesthesia, blood transfusion, cesarean sections, and antibiotics. The fact is that if there are there is still persistent high maternal mortality today anywhere, even today, even in the 90s when this study came out, is primarily because those technologies have not reached everyone who needs them. Simple. And these are not difficult technologies. These have been available to developing countries ever since they were available to developed countries. Still, that has not been achieved. So through a lot of painstaking research, it was shown that you need to get women to institutions to deliver babies so that they can access emergency care whenever required. That antenatal care can only go a certain distance. Beyond that, it's not going to help in reducing mortality in mothers. That you need emergency medical and emergency obstetric care. That is those 4 technologies that I talked about. And that if you look at the data, and if you, let's say you have possibly some 30 high risk because of for a high risk pregnancy, to label a woman as high risk, you have, let's say, 30 criteria. If you apply all of them, as I said, maybe 60-70% of all women will be labeled high risk. The whole point about high risk is to identify a few women so that you can give them better care and then have a chance of saving their lives. What they found was that, yes, it's true that if you use a long list of high risk criteria, then you will end up having a lot of, practically all women who are likely to die, you will capture. But for doing that, you will identify almost all women as at high risk. If you reduce this and say, oh, no, I'll use only these 4 or 5 important criteria to say these are high risk, right? So let's say bad obstetric history, you have low height or whatever else. If you just used those, then the number of women dying are much more among the non-high risk that you left out from your identification. And those who were identified as high risk, they are dying much lesser. Now, this kind of an understanding is what changed the whole policy from saying you do antenatal care and TBA training in high risk approach to say you assume that every pregnancy is at risk, make sure that complications are identified on time and treated in institutions. In order to enable that, make sure that women deliver in institutions. This is how it changed. So this is one example. Takes time to change. Okay, sorry. COVID, all of you are very, very familiar with, right? And normally it takes at least 10-15 years for a new finding in research to translate into action in programs on the ground, right? That is, in particularly in large government programs or even in private sector, to actually come into practice. COVID was an example of how quickly research was converted to action, very, very quickly. And that is true, as you are aware. I'm not going to get into details, but it was true for how quickly the tests were developed, diagnosis was established very quickly. For prevention of transmission, what needed to be done, that was elucidated. Lots of mistakes were made, but it was elucidated. Case management, how quickly remdesivir and other drugs came, were prone to be useless later on, but at least all that happened quickly. And finally, we came to know that except oxygen, nothing else really works to save cases. Vaccines, it was, when they came in, it was, we thought, no, we had solved the problems. We had never developed a vaccine within a few months of a new organism coming up. So we thought we had won the battle. Then we came to know it only saves people from death. It does in huge numbers, but does not prevent transmission of infection. So you cannot, it cannot stop the spread of disease. And then there were lots of lessons related to pandemic management of this isolations and the different kinds of ways of confining patients to some areas so that they would not spread the disease and so on and so forth. So we've seen all of that. A lot of mistakes were made. Okay, one of the biggest mistakes that were made, which actually contributed hugely to infections, was the failure to identify early enough or acknowledge early enough that it was an airborne infection. That it was not a simple droplet infection, but it was an aerosol-borne infection. And that difference was because of the way that conventionally WHO had defined what is droplet infections and where that came from. It came from tuberculosis, where droplets that were defined as between 5 to 10 micrograms, micrometers in size, and they are expected to not go beyond 2 meters, and they would then settle down and then maybe raise again as dust. But that because that they said it is airborne, they said it is droplet, assume that it is going to be only 2 meters, and that's why the social distancing there, that's where it came from. The fact was that the main problem was that it was an aerosol infection. Any closed space was extremely dangerous, and tell people don't go outside.
यशोद ही कर रही था શ્રીધર અવાજ નથી આવતો not audible. હવે અવાજ થોડોક આવ્યો
Okay. I'll try and switch my data.
શ્રીધર અવાજ
હવે સંભળાય છે?
Try to your video off. Maybe network problem there is. If a video will be off, Sound will be perfect.
I switched off my video, but it switched on again on its own. Can you hear me now?
Yes, yes, now it's perfect.
Okay. Yeah. So, okay. I think this will be more stable. I've put it on my own. So I'll share screen again. Can you see my screen? Okay. Can you hear me? Am I audible?
Yes, yes.
Okay. Okay. So anyway, the point is that, so this whole, for example, where did this data come from? The data that told us very clearly, the evidence that told us very clearly, this is an aerosol-borne infection. It did not come from medical research. It came from physics research. As early as March or April of 2020, there was a long blog by one physicist who argued in very simple terms that this is how aerosols behave, this is how droplets behave, and that there is no need to, or there's no point in having this 2 meters of social distancing. What matters is ventilation. So that took another 10 months for WHO to acknowledge, for the simple reason that WHO is very rigorous in the way that it processes data. And they did not have evidence to show that it was aerosol borne. So they kept saying it is droplet because we have said it once, it is droplet. Now, these are the limitations that are there in how actually research gets translated into action. Let's take the example of malaria. Lately, all of you are familiar with the Panama Canal because President Trump wants to buy it, right? He wants to take over the Panama Canal and so on and so forth. Incidentally, the Panama Canal was something that was built by the US around the turn of the last century, 20th century, early 20th century. Before the US started building the Panama Canal, the French had tried to build it. And then the US took over because the French lost something like some phenomenal number of workers, some 25,000 workers because of malaria. And they could not complete the digging of the canal at all. The US came up, they also lost a lot of people. But around that time, Ronald Ross and others came up with the understanding that this, what you're calling malaria, is transmitted by this parasite. And this is how you prevent it. And that transformed everything. The Panama Canal got built the moment they learned how to control mosquitoes and prevent transmission. That's a story of the Panama Canal. Similarly, the world wars, in both world wars, more lives were lost to malaria than the action itself, than the trauma sustained during actual action. So we know that malaria was extremely important. And yet, in India, at least, we came to very close to eradication in the 1950s through a massive DDT spray program that was going on. And that was based on a very, very strong monitoring system, which was strongly data-driven. Which village used to be covered? How many times has it been covered? When? Every single bit of data was very carefully collected. There were 10 layers of supervision of the spray worker. And that's why they were able to achieve an excellent level of control. And then there are lots of stories about why it came back, but I'll not get into that. Later on, of course, at that time we were not, the falciparum was not very prominent, but later on it became, especially in those areas where there's tribals, hills, forests, falciparum became the major carrier of malaria, transmitter of malaria. And And in all these places where today we know they are very well known for their very high rates of malaria incidence, Odisha and the entire Dandakaranya area, the northeast and so on. That is where falciparum got its roots. And all of this came up, all of this was understood by an excellent system of malaria research that was prevalent in the country at that time. We knew a lot about malaria. There's been more known about malaria in India than almost anywhere else. Then we put into place what we call today the malaria surveillance system, where every single case with fever gets tested, treated, recorded, reported, right? And we believed that that was sufficient to control malaria. Today we are in a situation where from 2013-14, when we had a lot of malaria, suddenly by 16, 17, 18, malaria dropped dramatically in all states across the country. Lately, it is making a resurgence again. But today, what has happened is that we just don't have the data to say whether it has come back or not. Because people assume that malaria ठीक हो गया, चला गया, तो भी उसको surveillance करने की जरूरत नहीं है. There was no need for doing any surveillance. So almost all states stopped doing rigorous surveillance. Those systems practically have become redundant. Why did it happen? Because we assumed that the reduction in malaria was because of two things. In fact, we assumed that malaria had reduced and disappeared based on our surveillance system. And secondly, because we assumed that it was because of our technologies, basically bed nets and the artemisinin based combination therapy, ACT, right? So which was widely used. It was available also in the private sector. So I'll not get into why malaria actually came down or did not come down. But the fact is that the major limitation of this surveillance system was that at any given time, even at the peak, it was capturing just 5% or at the most 10% of all cases in the country. But it worked because it was a representative sample of sorts, right? So it worked. But when the incidence becomes so low, now today they don't even know Kaunse block mein where malaria is. We just don't know. And it suddenly comes up and we say, where did it come from? So that's how data systems are built and broken down. And just to wind up, therefore, there is a lot of there's a lot that we need to understand about how data is generated and used in healthcare. And I've just picked up a few highlights to say in what ways, what are the main principles underlying this data use in practice, in actual practice today. For all research kind of situations, you want to test a vaccine, for example, right? So what you're doing there is testing a hypothesis. You use probability sampling, and that is restricted to mainly different kinds of research. In large-scale programs, there is no chance of a control area, right? In an RCT, for example, you randomize the patients or the people you want to test into either the intervention arm or the control arm and compare over a period of time what happened. In a large-scale program, you don't have that luxury. The only thing that we can do in a large-scale program is through service data, see if you're bending the curve or not. In fact, either service data or specially collected data. For example, the SRS data that gives us, for example, let's say maternal mortality, neonatal mortality, infant mortality figures, that the best thing you can do is to see if the curve is bending on. And that has become one of the most important ways to say if large scale, through data, whether program is working or not. To explain further, you use a mix of methods. You never trust a single method, right? And you don't trust a single source of data. So you use different methods, and that's what we call triangulation. And mix of methods here basically means you use qualitative data as well as quantitative data. The quantitative data to understand whether change has happened or not happened, or there's a difference or no difference, and qualitative data to understand why something has changed, why has something has not changed. One of the commonest mistakes that we make, for example, in the use of data is confusing. There is, you don't have evidence for something or against something, right? For example, you don't know whether a particular, let's say, an Ayurvedic drug, it works or doesn't work. We don't know, right? We confuse that the evidence, the absence of evidence, we confuse that for the evidence of absence of effect, for example. So we'll say, okay, it is not effective because there is no data. In fact, if there is no data, what you should be saying is, I don't know whether it is effective or not that it's not, right? So that is one common mistake that we make. And another very, very common mistake that happens is this demand for saying there should be a single source of truth. That is, you should have one source. So eliminate all other sources so that there's only one source. We don't want any confusion. This survey will give us some information. Some other survey gives us second information. Our own service data is giving a third kind of information. It's too confusing. So stop all surveys. Just our service data is sufficient, is what many governments tell you today. So just stick to one source of truth. The fact in science is that there is nothing like a single source of truth. Truth is a matter of perception. And data only helps us sharpen our perceptions and make it easier for us to actually get closer to the truth. There's nothing like getting to the truth. So I'll stop over here and leave it to Avni to expand on this. Thank you.
Can everyone hear me okay?
Yes.
Okay, let me reshare my screen. Thank you, Dr. Sridhar, and thank you, Dr. Rajesh Mehta, first of all, for this wonderful opportunity. Just hearing Dr. Sridhar has been a treat in and of itself. I do agree with a lot of the things that have been said by Dr. Sridhar. And in touching on some of the elements, I do want to tie it in with, what can we do about the data, right? The idea is not for us when we look at a curve, and when he says bend the curve, what he's really saying is that something which gets you to 80% under the area under the curve is good enough. It doesn't have to be perfect for you to implement it, because if you're seeing that amount of change and you are able to make that shift, then the outliers are always going to be there, and you cannot spend a vast amount of your resources in attending to those outliers. So I think understanding that there's always a science of approximation in the data that we deal with is really important and valuable. And I think, sometimes when we say that like there's no single source of truth, spiritually, of course, there is only one truth, and we all see it in different parts. But in terms of why we have data and all these technologies that are existing today, it might be that nature itself wants us to learn more about how do we get to the core of this reality, and how do we reduce pain and suffering in patients, in people, in populations. So I think that's where I would like to thank Dr. Sridhar. I think it really gave me something to think about and reflect upon. I'd like to take a few minutes to just say, introduce myself. My name is Dr. Avni Desai. I have studied at Karamsad Medical College. Since that time, it's been a while. I came to Columbia University in New York, and have been also part of Georgetown University's, programs for biostatistics, and have done a lot of work in the data space. It was not I guess it wasn't a common journey for being a medico to land up in data, but Deloitte, many a time where I've worked for 7 years. I've also led the COVID Tiger team for NIH as the data lead through Deloitte. It just goes to say that never think about yourself as being in a box, because the real answer lies outside the box. So I never thought in my wildest of dreams that I would be a data person speaking on data governance and interoperability and things like that. Yet it's the exact same thing that people seek me out for today. My own small business is Advaita, and I mean, if most people know what Advaita means, it's the meaning of Advaita is in Vedantic philosophy, it's non-duality, like no two sides. That there's only one truth, and we perceive it in different realities, right? So I'm going to start with the topic of I know Dr. Sridhar talked about the trees, the forest in the trees. I'm going to take it a notch up higher, and I'm going to talk about the forest view and why it's important to have the forest view. And those of us that do have that forest view, what do we see from there? So my next slide is going to talk about mainly what is data sharing and how does it impact all of these analysis, all of these things. So you're looking at raw data, but I do want to be mindful and say that a lot of things are done. Cleansing is done, cleaning is done, curating is done, metadata tagging is done. You're looking at patterns, you're looking at correlations. And this data, I mean, I don't want to say that it is only the healthcare space where data is key and valid and important. I mean, look all around you, your stocks, your markets, everything that is on the Dow, everything that is on the S&P index, all of that is some form of data that is being analyzed and used. And in any business, actually, if you look at it from a macroscopic view, you are making your decision based on data because that is called evidence-based practice. And that's a big thing in medicine, evidence-based practices, evidence-based workflows, evidence-based analysis. So all of that to say that if we don't rely on data, our decisions, our conclusions are less likely to be informed about the whole picture. So that is the reason we use data analysis. And then the importance, of course, like I can give you the example of COVID because I think that's where I was pulled in. I was probably at that time one of the only people Deloitte had hired from the public health space. And they always used to tell me I'm like a unicorn of sorts because I'm at the intersection of medical. I'd done clinical research for 15, 17 years before I'd ever entered that space of, consulting. And I had the background on regulatory because I'd done things for the FDA and National Institute on Drug Abuse. So I became a sort of a unicorn where I could understand data. I knew how it was housed. I knew how, what do you do with the insights? Because there are people who will look at the data and say, okay, this is the significance. It's very significant data, but it means nothing. From data and analysis comes insights, and that is what is valuable. So I think from the COVID pandemic, the first thing I can tell you is that the ability to fast track and emergency use authorization approval for COVID vaccine and the treatment that was literally handed out at rocket speed to folks, the one medication that was fast track approved for this would not have been possible without the fast and the furious team that was supporting that the entire effort. They were even let's forget COVID, right? Even before, when the world has seen pandemics like the Black Plague, it's in polio. All of the eradication has happened using data and the surveillance that has been done. And I agree with Dr. Sridhar. You take away the funding from the surveillance, and then you wonder why did this thing blow up in our faces? Because that's what we don't accept, that this is an ongoing effort that will need some amount of resources, but to the larger end, it is to protect people, it is to protect public health, and to protect the what's right. If it's going right, let's keep it right philosophy. So I mean, I did learn something that I want to share with you here. A lot of the time women are not considered to be when you think of data, you're probably thinking of a guy sitting at a computer and crunching away numbers. I completely disagree with that stereotype. I will share something that I learned in Mailman School of Public Health at Columbia. The first lecture I attended, I was so happy and so surprised to learn that truly, when that first outbreak happened, when John Snow in England was trying to find out, like, well, what are we going to do about this? Nobody knows the reality that it was his research assistant, a female. And in those days, they were not even allowed to share outside their office that, like, if Lord forbid, if somebody knew that the assistant was a female, she would not be taken seriously. So John Snow literally became the doctor who took her data, published it, and became known as the father of epidemiology. And yet the entire credit actually was the female who said, this hand pump in this part of London, in this part of the community seems to be having the most cases. I mean, there's something odd about that. So I don't think we should fall to stereotypes, but again, I did want to share that. There are lots of other uses in healthcare space itself. Like if you look at the hospitals within the US, I have been part of a couple of them where, they're controlling infections. I'll take an example of NICU infections. So what they do within the US is at least to kind of set up the departments to compete against each other, like a star system or there are a variety of ways that project management can use to monitor metrics and performance indicators and kind of do that in a way where it's like fun competition. So if my department's NICU infections are lesser and cardiology, let's say, has more infections, then I get the prize or I get recognition or whatever. In that sense, it's a very congenial atmosphere within the environment of the hospital because it is driving the outcomes, but in a fun way, because then data becomes something you strive for and not something you're just going to monitor and like, yeah, what can we do about it? No. You can improve those outcomes because there are measures that can be taken. There can be checklists that can be put in place. There can be a ton of things that can be done. I mean, if you look at surgical outcomes, only correct hand washing and following the 7 steps of hand washing, surgical hand wash, literally has changed the way that people in the operating theater can control infections. So that's all of this is to say that data has done a lot in public health space and also the understanding of medicine. At the core of it is all data. I mean, how do we know that something like aspirin, which was only used for something like, it never in your life you would have thought that I would use this preemptively to prevent like a clot or something, because we studied the side effects, because we looked into it in detail, the data was there to support it, and then to verify it, a randomized control, clinical control, a control trial was done. That's how we know that, that is that valuable. So sometimes it's like you're not looking for that, but those who can find those patterns, those who can identify those patterns in the data, have a flair for it, are really very valuable in understanding how do we tackle something like this. I'm going to the next slide. So what are the main types of data analysis that would be used in healthcare as specifically? So, you have your descriptive data, like what happened exactly, diagnostic data, like why did it happen? Can we look at an X-ray? Can we look at a CT scan? Can we look at the identity of the tumor? Like, can we HLA type it? Whatever it is that you want to do with it, all of that actually form discrete data points and elements. And the prescriptor, like what should be done. And I think there's one more in medicine that most people forget is the prognostic data, because that's how we know with surety. Like, for example, if somebody comes to a patient as a patient with like this kind of cancer, there is an actual statistic that the doctor will give out to you and say, you have this many months left, or this is what I've seen in a median survival. All of that is not possible without you knowing that there's a study that is done years ago that continues to be done to understand, like, patients with like myeloma or multiple myeloma, what is their average lifespan? It's 12 to 18 months. Why do we know that? Because that's been studied for many years, not just by the pharma companies, but by people who are genuinely interested in understanding the etiology of the disease, the molecular basis of the disease. So all of that is all tied in together. So, I mean, there are 4 kinds of studies that people really rely on. In the public health space, they are a little different. So when you see a PubMed or any journal that you pick up, you'll see a case control study or case studies or reports of like a single patient, and people will talk everything about it or why it was different, unique, etc. But then there's also the prospective, your longitudinal cohorts, like the PATH study, which was the largest study done on tobacco ever funded by the FDA, done by NIDA. I was a program manager on the study, and I was seeing the waves of patients that come in and seeing a data set with at least 200, 500,000 people. I should say it was very overwhelming, but very rewarding, very thrilling experience. And to understand that, when we're looking at it, we're like, okay, there are certain things that I saw, for example, why are e-cigarettes, for example, they have flavors like, they have watermelon flavors, they have bubblegum flavor. I mean, some of these things made me ask questions to my leads, because I said, well, this seems that it is targeted to a specific pediatric audience and not necessarily, I don't know any adult who would buy bubblegum flavored vaping tobacco. So it seemed odd to me. And when I raised it to them, sure enough, there's a paper now that's published on why they're targeting the wrong audience. I mean, you're trying to encourage youth to do vaping, which, it has now since stopped because of that data and because of the policy around that data and litigation around that data, using that data. Then the next one is randomized clinical control trials. So this is mostly in the pharma space. So like if I want to prove that this is the standard of care versus now I'm coming up with a new drug, I'll just call it ABC. Drug ABC is better than the standard of care. How do I prove it? Because I have to have two arms where they'll be randomized, double blinded or blinded, and then one part will know what the study drug is, or maybe they don't even know. In fact, sometimes there's even double blind when the investigators don't know which patients have received the drug or not, because that ensures that there is no bias in the recording of the data. But all of those studies are actually gold standard, but to do the gold standard requires a lot of money. So it doesn't just get pushed to that level immediately. It actually goes through 4 series of clinical trial analysis and data. And for folks who are more interested in learning about that, I do have a training on my website, which is all about whatever you need to know about clinical research 101. There is an entire training with modules in it about that. But now we're also in a new phase, right? This is the latest and greatest with FDA, NIH, all of the pharma, everybody who's trying a new product and a startup in the market. You have to look at real world evidence and real world data. Now, what does that mean, right? I mean, it's thrown out very often, but being a SME in that area, I'm telling you that it's not very easy, but it is very rewarding because you are looking at the existing patient data and spooling that with simulation data and then coming up with a forecasted model on how things could turn out, perhaps with the flavor of what that population has. What do I mean by that? No human being that I know of or that anybody knows of is a singular individual with only TB, only cough and cold, only cancer, or only hypertension. I mean, we don't exist in siloed, health issues. We are a core human with a ton of issues in any or every system, and we come with multiple comorbidity lists. Now, whether or not that can be factored in is the goal of RWE, RWD. So more on that, I guess we need a whole different session just to talk about that, but that's the essence of it. So you're looking at synthetic data, you're marrying it to real world data, and then you're trying to simulate a forecast on how it would predictively turn out to be in different scenarios or in different situations. And that really helps because if you can forecast, it saves you a ton of time in doing actually the studies and wasting years and time and waiting for the answers. You can more or less have a guesstimate on how it's going to go and then pick the right direction and move forward with just spending on that. So that's important. Okay, so this is about data analysis process. So when we say data, we've been all saying this word so casually, but there's a ton that goes behind it, right? So you can't just collect any and every endpoint that you want to collect, because every data point comes with a price tag to it, right? Like you have to collect the data which will provide an end outcome that you're monitoring, that you're tracking, that will give you an answer that you're looking for. So if you look at it from that perspective, you start collecting the data. That's not sufficient. Then let's say we put a lock on the data at certain time intervals, which is what most pharma companies do. And then you clean the data, because why do we need to clean the data? I might be a nurse in one hospital who has entered the weight of the patient as 65 kilograms. And there's another nurse in another hospital who made a data entry error, for example, that says 650 because she didn't know she was pressing that, but in a hurry, that's what she had to do. Or even worse, she picked the wrong unit. She said it's not 65 kilograms. She said it is 65 pounds. And in many instances, we are not getting data from just one hospital. If that was the case, that would be very easy. But you're getting data from multiple sites, sometimes across multiple countries. And that, when it needs to be analyzed, you need to clean it. You need to curate it. And what do I mean by curating it? In one data set, let's say something is called weight. The variable name is WEIGHT. That's not necessarily what hospital B, C, and D in 3 other countries have called their variable. So analyzing the metadata within the files to make sure it all aligns in the like the master data dictionary is ultimately curating it and making sure that you're comparing apples to apples and not apples to watermelons here. So you have to be sure that you are comparing things that are even worthy of being compared, because otherwise you're going to get a false answer and a false understanding that this is truly, correlation exists when really there's nothing there and you're just looking at the noise. Then there's also the part where you're interpreting the results. And I'll just give you an anecdotal evidence. There are so many articles that come out in PubMed, in the millions of journals that people have put out there. But there are very few people who can actually pick up a journal article and they look at the significance that the study has and actually tell you that this is not even worth reading. You're wasting your time reading the study. They don't know how it got published. I mean, less and lesser journals are even accepting such false data and falsification and blowing things and just printing things because you want your name on print is a long time thing that gone now, but hopefully it gets better. But again, that's a standard, right? Like, you have to understand that not everything that's published is significant, and that's a huge part of understanding biostatistics. So you want to follow a structured process so that there's accuracy and the relevancy. Like, just because something is published doesn't mean it's relevant, doesn't mean it's even accurate. So you want to be that data steward who understands, well, if it is beyond this, it means it is significant. I should at least take a look. But I would actually put on your thinking hat and read it with the, I wouldn't say devil's advocate, but be that sometimes, because you want to ask yourself, well, they did it this way. What have they missed in this? What could be done differently? How could they have analyzed this, collected the data, or the entire process? How could they have done it differently? Because that's what opens up scientific inquiry, and at the end of the day, your scientific question is what leads you to the answer. Hypothesis, yes, all of that, but you have to have before even all of that is your scientific question. What are you trying to establish here? What is your H naught? Even before you start with the hypothesis, is what is your research question? What are you trying to aim for? So that is something that's important. Collection and preparation. I think we talked about this quite a bit, but I'll just touch upon the newer sources here. Because traditionally we've all heard of surveys, databases. I mean, almost every association, American Heart Association, the American Cancer Association, all of these have a lot of databases, registries, state level registries in India. There's tons of those, World Health Organization records and all of that. So there's not a dearth of data, right? Because it's coming from multiple sources. And now people suddenly are realizing that we have EHR, EMR data, but oh my God, we have IoTs, which is Internet of Things, which is every device you're wearing, every phone you're carrying, everything like a Fitbit that you decide to measure something can all be valuable pieces of data. I won't go into it, but I do believe that one of my talks in the future is going to talk about the consent part for this, because a lot of the folks don't even understand that when you sign up with an iPhone, when you are signing up for a Fitbit, they are literally giving you 15 pages to literally zip through, and you're clicking I agree without understanding the long-reaching, far-reaching effects and impacts of your data being utilized somewhere else. It's, I think, less because HIPAA is not a rule in India, but it is in the US, right? So, I mean, even here, though, people are not aware of how much data, for example, Facebook collects on your health. You share something, you post something, social media is all around, but all of the pieces, everything around you, let's be cognizant, is collecting data about you. So you need to be prepared that when you share your consent, it will be used, and how it will be used should be something you think about. But we talked about, it has to be analyzable data. It has to be clean data, because otherwise what you get as output is not going to be, sound. There's a saying which goes in even computer languages. They say garbage in, garbage out. And it's the same with data analysis. So keep that in mind. The tools we use and the techniques we use in data analysis these days most commonly is, Excel is passé, it's old time. SQL is also dying. Nowadays, most people use Python, R, and it's gone from the phase where you had to write code and, SAS and all of that. We learned a lot of this when we were in 2006, 2008. as of 2013 and 14, we have all of these really fantastic visualization tools like Tableau, Power BI, and many others. Like literally, you drag and drop the data. You're doing your regression analysis, clustering of data, HPC clusters, all of that, and machine learning models, which will literally help the analyst extract the insights from very complex medical claims data sets or things like that. So it's very important in the sense that it's not as hard as it used to be. There's less coding involved. But of course, if something doesn't work, your knowledge of coding isn't going anywhere. Somebody will be needed to manually fix the code if the entire machine learning model isn't working. So tons of things like that. But again, it's important to realize that AI and ML literally go hand in hand. Why do they go hand in hand? Is because artificial intelligence is to simulate or like project onto the data or their insights into how a human would potentially do it. So it's a model, it's an algorithm, and the training of that model comes from the machine learning. Why? Because even as human beings, if you think about it psychology perspective, data is being used to train you. There's positive reinforcement, conditioning, all of those models that you learned about in medicine, well, all of them are actually true in AI and ML as well. So if you are looking at data and charts and graphs and how an effective visualization can slice and dice the data and help you in decision making, well, AI can actually do it without a human now. But the part where it needs the maturity is the model has to be trained. And that's where there are tools like Power BI, there are tools like Tableau, and GMP Clinical is something that, for example, FDA is heavily using. So those are the kinds of things that assist the person in doing something which is very labor intensive, to doing it very, very easily by just pick and drop, and you analyze it, and you might have to tweak a few things here and there. But if you know the basis of your data, if you know data, it'll be easy for you to play around with it. Common challenges. What I've seen at least is that the quality of data is really not all that easily excellent. It's very difficult to find. First of all, it's very difficult to find a complete data set. I mean, by that I mean, if a data set has over X number of missing values, it is extremely hard to analyze it. So then you have to use techniques to say, okay, if you're going to approximate, and if you're going to use things to simulate like what it should have been, you are starting with an assumption, right? I mean, and that assumption can be fraught with bias. It can be even biased during the collection of the data. Not only is the missing data in parts of the patient's record, it is the entire record is missing now. There are things like that happen, and you have to know statistically how to deal with those concepts. But I think the larger piece that's coming about now is the data privacy and protection, because with all the cloud things moving into the cloud, you have private clouds, virtual VPCs, and all of these other things. There are different kinds of clouds. I think people need to know that also. There is the private cloud, there is the public sector cloud, at least in the US. There are different kinds and then there's the hybrid, there's a way in which public sector cloud can interact and interface with the private cloud and keep parts of which need to be protected, but then the other parts can be open to people's analysis. And I think I've been fortunate enough to be part of a program where the model of like my mentors at Deloitte have been part of that, the data commons, and how can you build so-called enclave of data where you see the data, you analyze the data, but you can't print it, you cannot copy it, you cannot screenshot it, nothing. You literally will walk away with the analysis, and a piece of what you've done will be sent over to your email, and that's all you get from that. But you do get what you need, like that data set. So if you look at studies like All of Us research program, which has the largest patient data conglomerate ever, it has a lot of data, and it has genetic data, it has genomic data, it has a lot of data that could be very beneficial to human research. So you have to realize that everything comes with a constraint, and you're working within those constraints to get the best path forward. And that's always going to be an uncertainty that we live with, be it in medicine or be it in data. The future of data analysis. I think this is a very interesting topic. For full disclosure, I am trained in 5G and edge computing by innovation side in Deloitte, the innovation hub. And I've done a lot of use cases in, how can the life science and healthcare industry use 5G and edge in, let's say, taking a drone and dropping things for, first responders, like in an earthquake situation or a fire situation or wildfires or whatever. Those are the types of use cases that I've helped develop, but they've been also sometimes very specific to hospitals. Nurses, for example, get attacked a lot by patients who are not happy with how their family member was cared for or what have you. Even that is something that 5G and edge computing, from a data perspective, can pick up. And because of the low latency, they can actually help monitor the parking lots of hospitals so that the nurses can be kept safe. So those are things that, most people think that it's not within the realm of healthcare. When you're thinking of healthcare, you're like just disease, disease, disease. There's a lot more to healthcare than just disease. And there are people who are trying to do the right thing, right? I mean, nursing is a very, very labor intensive process. I mean, you're emotionally and very much physically, it's a very draining process. And to understand that their security and safety comes first, I think if you can use technology for something like that, it would be really very transformative, both for the hospital scene and also like people would want to go in healthcare. If you know that you're safe doing what you love doing, I think that's a great feeling. And emerging technologies, I think, I can speak to all of these separately. It would be a different lecture in itself, but AI we talked about. Blockchain is kind of like, you talk about the ledger system, right? I mean, in accounting, that concept of the ledger is now converted to a more or less digital medium, which is called blockchain. And how that would work, like I'm taking a sample from a patient. I don't know who that patient is. I've seen 3 other patients. But in that process, if I've been able to tag the patient's vial, the test tube or vial with all of the things that, I print the label using blockchain technology and I'm tagging it, then throughout the life cycle of that specimen, that particular code and that, the blockchain element will be the ledger ID for that patient specific sample in the entire chain of wherever it goes. Imagine that. Whether it was stored for years together as a pathology sample, whether it is tested, you do a Western blot or whatever blot you want to do with it, whatever you do, what if there was something always tagged to it to make sure that it is always connected to the right patient's record? That is, I mean, that is exactly what's happening nowadays. Internet of Things, again, we talked about IoT devices. They're looking at a lot of devices in the healthcare industry. I've heard of one, and this is very, very interesting. There's a payment device, which literally it is a device used in Australia. There's a lot studied about it, but basically it's something where the data for what patient medication has been given to the patient is fed into that little device. And what it does is the patient takes it home, especially older patients. They are actually taught to use that data and get answers from the patient in their questions, like, how do I take this medicine? So they can, instead of asking a person, they can ask that device, like literally like how you're talking to Alexa, you can ask that device and it is completely protected. Your privacy is protected. It will actually walk you through how to take that medicine, whether it needs to be crushed, whether you should be biting on it or chewing on it, whether it needs to be swallowed whole. Will you take it with the meal or not take it with the meal? If you're facing side effects, what do you do with it? Like literally like a small pharmacy assistant is coming home with you. And that in itself apparently has reduced the loneliness felt by patients in countries like Australia. So it's very interesting to see that the uses of data in even the human aspects and the human design of things. I think I'll stop here. But ultimately, what we want to do with data and these technologies married together is to drive these decisions in the right direction. Reduce costs. You want to improve patient outcomes and improve the landscape for health, and hopefully prevent disease before it even becomes a disease. I think this one slide is additional. Again, this is an entire lecture on its own, but interoperability and data standards is something that is the focus of NIH and a lot of institutions right now across the world, because we have found that data is there in silos. And I've kind of led some of their major interoperability initiatives to understand how do we make these data sets talk to each other, because it's not as simple as saying all the variables need to talk to each other. No, there are standards for data. There are codes that you have used. So like, for example, we moved from ICD-10 to 11. But even within the US hospitals, that transition happening itself will take 3 years. So while we complain in India that this is taking forever, it's not that the rest of the world is also, moving at rocket speed. Every place has its own challenges. And I think just being cognizant that the fastest tracks, like, would be like data standards like GA4GH or HL7 or FHIR standards. Everybody wants to be able to provide insights where the end user, and by end user in the business, I mean patient, right? Like it can be a child, it can be an elderly person, it can be your family, it can be you. But you want to improve the care and the well-being of that person. So it doesn't happen without the data talking to each other. So I think I'll stop here. And if there's any questions, I am happy to take them. Same for, I think, Dr. Sridhar.
Yeah, sure. I'm available.
Ave, now I think both the presentation are over. So if someone is interested in asking few questions, we have few more minutes. And basically, I personally feel that those who are interested in this should form a group upon a specific topic. So although this number was very small today, because we had not done a systematic efforts to cap the population, we had just done an organic boosting, and then at least 60 people registered and 17 people remain present. So if anyone wants to ask a question, can do it now. Dr. Lakhani would say some few words.
Yeah, say both the talks were excellent. I wanted to know how ethics would come into picture, because as Avni said, that many times the data is being collected without our knowledge. So how much fair it would be to analyze such a data?
I can take that, or Dr. Sridhar, if you want to respond first, and then I can tag on.
Please go ahead.
Yeah, so ethics is a very important topic, Dr. Lakhani, and I believe you are Dr. Jitendra Lakhani from the HOD of Medicine when I was studying there at Karamsad. Am I right?
Yes. Yeah.
So nice to hear your voice, sir. Yeah, I mean, it's important. I think most people right now don't realize what vast amounts of data you are contributing to. And I think I'm a big proponent of consenting of patient data. There are things called data use agreements, which typically should be in place. And if you see any institution which is reputable in nature, like an NIH or an FDA or something, all of them will be asking you, even if you submit data to the FDA, the first thing they will ask you, and having worked there, is basically they will ask you, do you have the consent of the patient? All of these things are not something that these folks take lightly. I have actually consented patients, thousands of them, on things where, like, they're very tired of going through the 10 pages of the consent, and they're just willing to sign away. But I take my time, even if it's an hour and a half, to explain to them in layperson language why it matters. Because I mean, these are old folks sometimes, they're very young folks sometimes, and it's challenging in the pediatric population. It's not even the pediatric patients who are giving you the consent. It is almost like the parents are going to consent for you, and does that carry on? I don't think so. It shouldn't. But typically that's what happens. So you want to understand the ethics piece and all that, but there is a thing called the IRB. Now, if it is happening within the clinical trial space, there is an institutional review board which actually monitors all of this. If it's on the medication side. Pardon me?
बस ठीक है
Hello?
यार एक मीटिंग चल रही है मैं आपको बाद में करूँ कॉल
Dr. Sridhar, are you trying to say something?
Yes.
No, I'm not.
I thought
Okay.
I just thought I got a notification.
Oh, okay. No worries. All right. So I was just saying that in the data space, where, I mean, it depends on where you're talking about, right? Like, I mean, if you're looking at clinical trials, there is an IRB. There is an actual body called the Data Safety Monitoring Board, DSMB. There are things that guard and safeguard both the rights of the patient, how the data should be used, to what extent can you collect the data, and what data is off limits, right? All of that exists, and that's the framework. That's the regulatory framework which the existing clinical trial industry uses. Outside of that, when it comes to devices, I think there it was a little skewed, but as most things, NIH has taken the reins on that, and the last I think I understand, FDA has come out with guidance on device data and how you can regulate that data and all of that. There was some guidance, I want to say last March, that was put out for that. In addition, there's also data with all of this AI and modeling and everything else. Folks sometimes forget that there's a fine line between somebody consenting for X purpose and then you using that data for a completely Y or Z purpose, and that happens. I'm not going to sit here and deny that I have not seen cases of that. It is blatant, it is going on, but I think that's where some of us who do, technically we've been at bedside, we've been at the patient's bed, and we know what it feels like to stand in those shoes. Even to just treat them is that hard, and take their pain and understand that. We are the ones who are like speaking up and saying that this is not okay. I don't feel comfortable with that. I don't feel comfortable with you using this patient's data without their knowledge. So I think in any industry that would happen. Like, there are those who will say yay and those who will say nay, but we need more of the naysayers if the wrong thing is going on. I will agree with you on that.
Actually, ma'am, may I ask question?
Yeah, go ahead.
Ma'am, good evening, everyone. Myself, Dr. Pratik Goyal, doing MD in Community Medicine, AIIMS Bilaspur. Hello, yes, ma'am.
Yeah, nice to meet you. Go ahead with your question.
Okay, ma'am. Ma'am, actually, the question is, the NFHS survey show that the malnutrition or stunting in Himachal Pradesh is approx 20%. But as per our study, we do study, it is only 7%, 8%, 5%, like that. So how we change our intervention, how we change our planning, policy, program managing? Please guide us.
I think that's a better question for Dr. Sridhar. If I can give you an answer in a very few lines, it will depend on how the PM, the project management and the portfolio management happens. My understanding is you will get the resources from a UNICEF or from an agency that is outside of where you are, right? I mean, that's how typically the funding works. So what I would do is make your case in a way where your data speaks for itself. It's not important just to do the analysis and paste it on slides and hope that they will understand. Data is a lot about data analysis is storytelling. How does your data tell the story that you want heard on the other side? It is storytelling, and it's a craft, it's an art in of itself. I had a lot of professors. I remember from Dr. Karam sir, I had the HOD of surgery, and we used to ask him, is this an exact science? Like, how are you so sure of what we are removing from this organ and all that? And he would say, a lot in medicine is not just the science of it, it is the art of it, and the same thing with data. If you look at it as a discipline of actually an extension of medicine or anything else, it is all information, and in all information, it is not the potency of the information, it is how the recipient absorbs it. what he or she is going to make out of that. Because if they are the decision maker, your best chance to get that funding is to explain that story in a way that hits home with that person. It has to touch their heartstrings, regardless of what the data says, you know. So that's just simple. I'm just saying it that just ये कहने से कि ये कोरिलेशन है, वो फंडिंग नहीं आने वाली। ये कहने से कि बहुत बड़ा प्रॉब्लम है, तब भी फंडिंग नहीं आने वाली। आप अपनी स्टोरी उनको इस तरीके से समझाइए कि आपका जो मतलब मूल सूत्रधार जो स्टोरी सुना रहा है, वो उनके हार्ट की स्ट्रिंग्स, उनके दिल के हर एक नस को छू सके, तो वो बात बनेगी, तो वो फंडिंग आएगा।
Okay, ma'am. Thank you, ma'am.
Either should we wind up now or you have something to say?
No, we can go ahead and wind up. You
Yeah.
can say whatever needs to be said next about how we want to take this forward.
So I think
The only just one second. The only thing I really want to say is I missed saying hello to Dr. Lakhani. So
yeah.
Hello, Sridhar.
Kem cho, sir?
Yeah, I loved your talk, and it was really not only medical, but there was some spiritual inputs also. I loved both of you, huh? The lectures, which were very good.
Thank you so much, sir. That means a lot. Please go ahead, Rajesh.
Tejas, how do you find? Dr. Tejas, how do you like? Anyway, we are winding up, but I think we should have such kind of dialogue on this virtual platform, which is free from any bondages and which seeks truth and the future, the ideas, etc. will be floating in a WhatsApp group and then boosting across the nation and across the world. And thank you both the speaker for a very live discussion and the presentation. And also thank you Dilip Bhai and Dr. Lakhani and other the listeners. Thank you all.
Thank you all.
Thank you all. Yeah.
See you next time.
मानसी बघितलंस का आम्हाला नेहमी स्वतःच्या नादाचं कौतुक करत असतो पण आता तू सर्वात महत्वाची गोष्ट विसरतेस काय तुझ्या लहान नशिबाने त्या इतकी सुंदर आणि मिठा बायको मिळाली पण कौतुक तर वालीचं अजिबात नाही करायला हवं माझा दादा सारख्या नावाला शोभच सापडणार नाही अगदी बरोबर मुली सांग आपण पण ना तुझ्यासाठी असाच प्रेमळ हुशार आणि हँडसम मुलगा ठेवणार तो दिवस आता दूर नाहीये पण तरी माझ्या दादासारख्या नवरा नाही सापडणार पण तो योग्य ठिकाणी शोधत